Welcome to the Acute Medicine Training Programme in the East Midlands. This brief video is to explain to you everything you need to know and what you need to do for your annual review of competency progression, or ARCP. In the East Midlands there are two training programme directors, Dr. Lee Walker, who's in charge of your rotations and ARCPs, and me, Dr. Nicola Cooper, who's in charge of teaching and learning and the regional training days. So first things first, it doesn't matter how good you are, you have to provide evidence of satisfactory progress in your training programme. And the only evidence that is accepted by an ARCP panel is evidence that you put on your e-portfolio. Let's start from the beginning. It's really useful if you upload a photograph of yourself on your e-portfolio for when we're looking through things. And what we need to see at ARCP is that you've signed yourself off, and then your educational supervisor has signed you off for the 4 emergency presentations by the end of your first year. And then you need to self-sign off, and then your educational super signs off for the rest of the curriculum across the remaining years of your programme. Every year we also need to see the required minimum number of work-based assessments. It's a minimum, you can do more than that. And as a prompt we have an ARCP checklist which you can use to go through with your educational supervisor before your ARCP. Just to go through things like your specialist skill, whether you've completed your SCE, and the required deanery courses, which are a communication skills course, management and leadership course, and a teaching course, whether you're completing your logbook, attendance at training days, conferences and so on. This checklist basically summarises all the evidence that you need to provide at every ARCP. This is a part of what it looks like. It's just a prompt for you to make sure you're not missing anything. In the new programme there won't be that general medicine year. The deanery runs an advanced communication skills course once a year. There are various management and leadership courses. If you do a Chief Reg programme, that is your management and leadership course. And for a teaching course, this is free, it's online, Future Learn. This is a course which you do for a few hours over a number of weeks, and you can evidence that you've completed that. We'll take that as evidence of a teaching course. And here's the things that we look at every ARCP: the Educational Supervisor's Report, Multiple Consultant Report, the work-based assessments that have been done, whether a minimum number has been submitted, MSF, multi-source feedback, and whether you and your EdSup have signed off curriculum items, whether you've attended conferences and training days. We need a valid ALS certificate, and you must also submit Form R to the deanery. Please, it's very important, can you create a folder in your personal library called Specialist Skill, and in there put the evidence that you're working towards or achieving your specialist skill. That might include a logbook if it's something like ultrasound or echo, or a certificate if it's a certificate or a diploma. Now the curriculum we want you to complete is the acute internal medicine curriculum only. You don't need to fill out the Gen Med curriculum because you're just going to be duplicating. So just fill in the acute medicine curriculum only. Your EdSup can block sign off some competencies at certain stages of your training, but basically by the end of your training things should be individually signed off mostly. And if there are things that you don't get to see, like some GU presentations, then you need to register via the e-portfolio for access to e-learning, and then you can click on the e-learning icon for that topic to access it. Now we're also looking for evidence of reflective practice in the form of reflective writing. Most of you have never been taught how to do reflective writing, so here is a very quick guide. We only want brief details of what happened, and they must be anonymous. You then need to sort of say what you thought about it, and And what we want you to do is to reflect on what happened, to make sense of the situation. And a good thing to do is to reflect in the light of the literature or any feedback you got, what happened next, what the patient, carers or colleagues had to say. So reflective practice as a professional is looking at your practice through a different lens, through the lens of the literature or the patients or colleagues or any other feedback that you might get, like what happened next. And it's this sense making and goal setting, what you might do differently, and which is the learning from what happened, that we're really interested in, not just a description of what happened. And reflections can be done for anything in which it made you stop and notice. So reflections are not only for things that were bad, they're for things that were good, neutral or bad. Anything where you stopped and noticed and it made you think. Work-based assessments, we need a minimum of 10. Obviously, if you work part-time, for example, if you're 60% full-time, then we just need 6. This is the minimum. You can do more than this. So a minimum of 10, 6 of which must be ACATs. First, the multi-source feedback must include a self-MSF. You have to do that before it is released to you by your educational supervisor. So you have to do it a self one, and it should include 3 consultants as well as a range of multi-professional colleagues, a minimum of 12 people. So that's nurses, SHOs, peers, admin staff and so on. Once a year you need to do an audit that you're leading on, and one of those must be a quality improvement project or an audit in which you've closed the loop. You do need an audit assessment by CCT. You need a teaching observation by CCT, and we need evidence of your competence at certain practical procedures, which we'll talk about in a minute. Work-based assessments should be linked to the portfolio. There are various limits to how many curriculum items you can link various work-based assessments to, and we'll talk about those in a minute. It's important to know that you need 2 independent summative sign-offs for the life-threatening procedures. What that means is that someone says you're independent and able to deal with complications, and they've summatively signed you off. So these are the life-threatening procedures. The chest drain under ultrasound guidance doesn't mean that you're doing the ultrasound. It means that an ultrasound was guiding the procedure. Now, ideally, the assessors should be consultants, not other registrars. This might be different in intensive care, for example, where the registrars are much more expert compared to you. And we do accept specialist nurses for DC cardioversion lists. On the second page of the ARCP checklist, we describe the procedures that you need to do. Although your curriculum says you should be independent by a lot of them by the end of the first year, we realise that you won't be able to do this until you've done relevant jobs like intensive care or respiratory. But you certainly need to be independent by CCT. Now, there are some desirable but not essential procedures, and the Specialist Advisory Committee has recently said that although you won't be able to do these or even do them in a skills lab, we want you to get a CBD from someone, just exploring the indications and just so you know when they would be used. Strangely enough, the CBD for temporary pacing, you just need to do it for the percutaneous external pacing, not necessarily the transvenous route. Now, don't forget, you can get people to watch you do procedures as many times as you want. This is called formative assessments, where they watch you and give you feedback. Most people don't understand that formative assessment is helping you learn. Just because you weren't independent and able to deal with complications doesn't mean you've failed. It's called learning. So we're interested in that, as well as those final summative sign-offs to say that they're happy that you can do them. Now, the reason we do work-based assessments is for quality assurance purposes. That means the public knows that we're training doctors who can actually do things. We do it to identify your progress, and work-based assessments are really important for assessors watching you and giving you feedback, so it's important for education. It can help us identify difficulties so we can give you extra support. And let's go through these work-based assessments one by one. So the first is a mini CEX, that stands for clinical evaluation exercise. See, research shows that supervisors rarely observe their trainees. So a mini CEX is a way of getting your supervisor to actually observe you. It's called mini because it's just one of the history, exam or explanation and counselling. We're not watching you do a whole consultation. It should only take about 15 minutes. And you can link one mini CX to a maximum of 2 curriculum items. ADOPS is a direct observation of procedural skills, and again, it's watching you carry out a procedure. The assessor should be a consultant with the skills themselves to do the procedure. Again, the median time required is about 15 minutes, and you link this to the relevant procedure on your curriculum. ACAT stands for Acute Care Assessment Tool. It's your ability to run the acute take, see patients on the take. This doesn't mean you have to go and see 5 patients or someone has to watch you see 5 patients. We could discuss a few of them and go and see 1 or 2 of them together. Or we could in fact watch you see 5 patients, but it doesn't have to be. You need a minimum of 5, and we're assessing your ability in 3 or 4 different areas, like taking a history, requesting relevant investigations, management, and so on. You can link one ACAT to a maximum of 8 curriculum competencies. CBD is a case-based discussion. This should be based on one of your entries in the notes. So you're meant to sit with a set of notes and go through what you've written in the notes. It's an attempt to assess clinical reasoning, and we'll assess 2 or 3 domains like your ethical decision-making, your management decision-making, your choice of investigations, whatever. It's meant to be in a pre-arranged office setting. Usually takes around 20 minutes, and you can link to a maximum of 2 curriculum items. Now, most of the time, I've noticed trainees sort of have a chat with a consultant and then ask if you can send them a ticket. That is not a CBD. It's not an assessment if not everyone knew it at the time. Here's 2 people having a chat over coffee about the weather. After the conversation, the trainee says, "Oh, can I send you a ticket so you can assess my knowledge of cloud formations?" That was not an assessment, that was a chat. So you can't have a chat and then say, "Can I send you a ticket?" A work-based assessment is something where everyone knows it's an assessment in advance. This is so the assessor knows they're assessing. Now, multi-source feedback is where people are making comments on your non-clinical skills. So your non-technical skills, as it's known. You need a minimum of 12 people, plus yourself. That's the bit that everyone forgets. It must include 3 consultants, which can include your ed sup, and it should be a range of different professionals. The responses should all have been gathered within a 3-month period, and it's useful qualitative data. And feedback should be given in person by your ed sup at an educational meeting before it's released to you. It should only be released to you if those minimum requirements have been met, including a self-MSF. Whereas a multiple consultant report is about your clinical skills. And this is a minimum of 4 consultants that you have worked with that year, and it cannot include your ed sup. You're meant to really agree with your ed sup which consultants you're going to ask beforehand. And this is commenting on your clinical performance. It's basically a clinical supervisor's report, and there's good evidence that that expert global judgment is really useful. You also need to get 1 patient survey during your training. This is not a curriculum requirement, but it's a GMC requirement for revalidation. Now, the point of work-based assessments is to give you feedback. The point is to help you learn. Feedback can be really effective in helping you do things better next time. And we do a number of work-based assessments and a number of different work-based assessments because we're basically building up a picture of you as a trainee. And if you want to know more about work-based assessments, you can read more on the JRC-PTB website. So the summary is we need to see self, then your supervisor sign-offs for the 4 emergency presentations by the end of the first year. Self, then your supervisor sign-offs for the rest of the curriculum over the course of the programme. And the required minimum number of work-based assessments each year. But remember, we're also looking for those things in the ARCP checklist to see that you're on track, so that you're doing those required courses, you're attending the training days, you're on track with your procedures, your specialist skill, your SCE, your ALS, etc. Okay, so that's the end of this presentation. Please make sure that you do everything you can to have this all prepared before your next ARCP. Thanks.